Hi, everybody. This is Kara with Senior and Disability Services, and welcome to our presentation, Legally Responsible Individuals, LRIs, Providing Services in Alaska. And we have our director, Anthony Newman, to give us this presentation. We welcome you to participate in the chat feature, and at the end of the presentation, we'll do Q&A. And we'll also be able to open audio for folks to share over the audio part of your device, whether that's a phone or a tablet or any other device with audio. That being said, I'll go ahead and let you take it away. Thanks.
Thank you, Kara. Well, good afternoon, everyone, and welcome. I'm Tony Newman. I'm the Director of Senior and Disabilities Services at the Alaska Department of Health. Juneau is my regular work location, but today I'm coming to you from the SDS offices on Burgraw Street here in Anchorage, and I wanted to say thank you, Anchorage, for the chilly rain. It's making me feel right at home. All right, it looks like we've got a good crowd of about 100 people here, and I also wanted to note there are several staff from SDS on the webinar today. Kara, Lynn Kyleman Cruz, Cassandra, Kat, Rodney, Jordan, others I may have missed. I just wanted to say thank you to them for their support and their teamwork. These are extraordinary times of change and demands here at SDS, but the managers and staff here are being responsive and patient and hardworking, and I'm just very grateful to work alongside them as we seek to make our system and services work better for participants in our programs. Okay. So today I'm going to be talking about legally responsible individuals, LRIs. I'm going to use that acronym quite a bit probably, and the status of their ability to provide services through SDS's Medicaid programs. This topic has received a lot of attention over the past couple of years and has really heated up in the past couple of months. There have been some changes in direction and allowances on the ability for LRIs to provide different kinds of care. And my hope is that, if nothing else, we can reduce some of the confusion surrounding this issue in the 90 minutes that we have together. Okay. Let's see. This is our mission at the Division of Senior and Disability Services, to promote the health, well-being, and safety of individuals with disabilities, seniors, and vulnerable adults by facilitating access to quality services and supports that foster independence, personal choice, and dignity. We put this mission right up front along with pictures of people that we serve who graciously gave us permission to use their photos. I'm going to talk a lot about policies and rules in the minutes ahead, and I just wanted to be clear that our services are about people and they need to remain front and center in our minds. Okay. So some housekeeping before we get rolling. You're on a GoToWebinar, and the menu for a GoToWebinar can be found by clicking the orange arrow. This webinar is being recorded, so please do not share private information, including names or health data, in either the chat boxes or when we open up later for verbal Q&A and comment. You can type questions into the question box. You can see it by clicking again that arrow in the orange box. My colleagues are going to help monitor as we go along. Again, because to some people, engagement doesn't simply mean typing a question or comment, but it means asking or being able to have a little bit of verbal back and forth. So after I get through presenting some information, I'd like to try and give people a chance for their voices to be heard if they so wish. So if you would like to have your mic unmuted in the last 10 minutes or so of the presentation, type into the question box that you'd like to speak, let us know, and you'll be unmuted. This is an opportunity to comment, but it's not your only opportunity to comment. You can always send us questions or comments at the policy mailbox listed here. And I'm going to display that again at the end of the presentation in case you don't catch it. Okay, as we get started, I wanted to take a moment to discuss the term I'm going to use in this presentation, and that's legally responsible individual, LRI, instead of referring to family caregivers. Both these terms have been used a lot in the course of discussions and dialogue on this subject. And it's important for you to know why I'm going to be so precise in my use of the term legally responsible individual, or LRI. SCS works in a world of regulation, of course, where every word is carefully chosen. Right now, sorry, let me go back. Right now, in a couple places in regulation, LRIs are defined specifically as follows: as parents of minor children, spouses, and legally responsible persons. Family caregivers is the more user-friendly term, of course, but there's no real consistency when people say family caregivers, whether they intend to mean only a legally responsible person or not. I'll hear from time to time that Alaska doesn't allow for family caregiving, and I insist that people stop and explain what they mean by that, family caregivers. And I remind them that Alaska has always allowed some family caregivers to provide services, but has been specific about LRIs not being able to provide services. So I'm going to use that term LRI. And I'm going to make another note about terms. This is a very sensitive mouse, so I'm going to try and use it advisedly here. During the course of this presentation, I know people will have questions about the role they may have with a participant and whether they would fall into the category of a legally responsible person. In this slide, I've listed some of the various terms for people that have a decision-making role for participants. And I expect as we go along, some of you may have questions like, hey, I'm a power of attorney for a person. Is this saying I can be paid to provide care? And we'll answer those questions as best we can, but I wanted to start off by recognizing that these are areas of confusion and the current regulations aren't explicit in contemplating these relationships and how they relate to caregiving. So we know that as we develop the regulations around legally responsible individuals providing services, that we want to clarify the ability for people who have these roles to provide these services. So I want to just acknowledge that up front. Okay. I'm going to be talking about the role of LRIs in 3 different categories or buckets of services based on the federal rules that authorize us to use them at the state level. Though we have these 3 different buckets, the thing they all have in common is they are different programs under Medicaid, the Joint Federal State Medical Assistance Program. So if you are here with questions about how this topic applies to someone you know who is on Medicare or a military health program or private insurance, I won't be able to address how they work with or allow LRIs. These are all 3 categories of Medicaid services. And here at Alaska's Senior and Disability Services, we provide personal care services through the Medicaid state plan, and those are and then there are the services that are authorized under Section 1915K, also known as the Community First Choice Program. And finally, the home and community-based waiver programs that are authorized under the 1915C authority. In the blue boxes below these main categories are some important features of each of these service types. And I'm going to revisit this slide as I go along. But first, I wanted to bring you back to the spring of 2020 when COVID was just taking off and the federal and state governments both declared public health emergencies. The federal government provided a couple of tools that allowed SCS and other state agencies to change the conditions under which we operate in emergencies, offering flexibilities to the way we authorize and allow services. And they allowed these under COVID, given that businesses were shutting down. We were concerned about the safety of people going into homes and being in congregate settings and risking infection to others. People were quitting or getting laid off, all these terrible things that we're so glad to have behind us now. The 2 main tools that we had at our disposal were authorities that allowed us to make changes to all 3 of those service categories that I just showed. These were the 1135 disaster relief plan, and then the famous Appendix K for 1915C waiver services. And again, allowed us to adopt a whole host of flexibilities during the emergency. So the pandemic proceeded, got better, it got worse, then it got better again. And then early this year, we got word that the public health emergency was going to end on May 11th. And across the department, from healthcare services to public assistance to behavioral health to senior and disability services, we had to make plans for unwinding the flexibilities and changes that had been allowed. Most Medicaid state plan services were designated to end on that day, May 11th, as we'd known since the public health emergency began. We also knew that Appendix K would have a different end date, that we would get an additional 6 months past that for waiver services flexibilities that we'd allowed. So we were working off 2 different deadlines for the 3 categories of services that were allowed to have LRIs providing them. So I want to talk about where each of those categories of service now stand. So first, state plan personal care services. We have about 1,800 Alaskans that receive personal care services through the Medicaid state plan, which means that service is not authorized through the 1915C waiver program, but rather directly through the plan that governs most Medicaid services. I will point out that several states do offer their personal care services programs through a 1915C waiver, but Alaska does not. And that means that many people who don't qualify for a waiver because they don't meet an institutional level of care are nonetheless able to receive personal care services. So what's the status of legally responsible individuals being able to provide personal care services to the people that they know and love? Well, federal regulation is pretty explicit that the use of LRIs in Medicaid state plan personal care services is prohibited. That prohibition was lifted during the public health emergency thanks to the Section 1135 waiver. But all along, CMS has conveyed to us that this flexibility would end on May 11th, and there was nothing that could be changed about that. We messaged that throughout the pandemic through our e-alerts and other forums. But then, shortly before May 11th, like days before May 11th, CMS informed us that states could apply to allow state plan PCS to continue for several months longer, up to November 11th. So it made sense for us to continue that flexibility, not only because we believe people could benefit from it, but also because we thought it would be less confusing to have 2 different end dates for our flexibility. So we applied, and we expect to hear back from CMS anytime. It's been 5 months now since we applied, and we still haven't received word back. So we're operating in good faith that it will be approved and this flexibility will continue. So the bottom line here is that on November 11th, this flexibility will end, and legally responsible individuals will no longer be allowed to provide state plan personal care services. Okay, that brings us to the 1915K Community First Choice Program. Community First Choice was introduced in Alaska about 6 or so years ago as a means of authorizing services for people who meet an institutional level of care. And right now it is the mechanism through which we provide some personal care services, chore services, and personal emergency response systems, or PERS. As the first bullet here notes, LRIs were permitted to provide 1915K personal care services under the public health emergency. But then as it became clear that the emergency was winding down, advocates approached a couple of legislators. They approached Senator Kathy Giessel and Representative Genevieve Mina of Anchorage and asked them to mandate that the department continue to have this flexibility, citing that families have come to rely on this flexibility and would be in real danger of losing care without it because there aren't enough personal care workers out there. So Senator Giessel introduced her bill and eventually tagged it into another bill, Senate Bill 57, which was also related to home and community-based services. And that bill passed the legislature. As it was being finalized, we learned through dialogue with CMS that nothing really needed to be done on the federal government side to allow this change, but we do need to amend our regulations to make it happen. Because right now, the reg that I cite here, 7 AAC 127.015, forbids LRIs from being able to offer 1915C personal care services. So our goal is to amend the regulations by July 1st, 2024, And in the meantime, this flexibility will continue. But an important thing that is going to change once we do develop and complete those regulations, it's that we need to put up some guardrails around this service to make sure we are taking steps to ensure that participants maintain the full choice of providers and that we have some measures of protection against fraud, waste, and abuse, what we call around here program integrity. So what should these guardrails be? This question is one of the big reasons why we're engaging with you now. We'd like to hear from you, especially those of you that are a bit anxious about this change and allowing legally responsible individuals to provide services. I've talked to providers, some of whom have told me that they're anxious about allowing legally responsible individuals to provide services. Because for instance, how do you discipline or terminate, for example, a loved one who might be misrepresenting their service hours on their timesheets? Or how do you really ensure that a person who is nonverbal really agrees to having their own family member serve as their caregiver? So we'd like to hear from you on how we write protections for these kinds of things into regulations. For instance, we could propose that legally responsible individuals should have someone else sign off on their timesheets, just like I have to have someone else sign off on my timesheet, or if you operate a business, you know, it's just good control for protecting against fraud. What about having a limit on the number of hours a person can claim to have worked? When you're talking about having an LRI provide services, you're typically talking about someone who will live with that person, and it could get very hard to differentiate between when you're working and not working. So these are examples of some of the things that we're considering putting into regulation. We haven't started work on the regulations yet because we want to get your input on these. And I want to be clear that putting these guardrails into place will mean a tightening up of what's been allowed to happen under the public health emergency. There aren't any real guardrails in place right now, and undoubtedly, some people who haven't had to abide by the conditions that the kind of conditions I mentioned, aren't going to be pleased when we need to introduce some controls around how they can provide care. But like I said, they are important to protect our participants and the state's investment. So again, please, if you're here, especially if you're here on behalf of an advocacy group that can gather up input from your membership and put some thoughts together for us, let us know what you think good guardrails would be and what you'd recommend so that we can consider them and perhaps fold them into our draft regulations. Okay, so now finally, the last category of services for which LRIs have been allowed to be reimbursed for services. That's our home and community-based waiver services. Here in this final box are some basic facts about how the state's waivers are authorized. There at the bottom are the familiar acronyms for our 5 waivers: IDD, ALI, APDD, and etc. Now, under the Appendix K, we adopted a number of changes and flexibilities, one of which was allowing LRIs to deliver some waiver services. And while there are about 16 or 17 various services on Alaska's waiver menu, only these 4 have been allowed to have LRIs providing them. We understood that this allowance was going to end on November 11th, like all the Appendix K flexibilities, but then in the early summer, we started hearing rumors that CMS might be changing the terms under which flexibilities could end. And all summer long, we had nothing firm from CMS until just about a month ago, when they released a letter saying, yes, flexibilities can continue past November 11th if, and this was a big if we submitted waiver amendments before November 11th. So that's when we started hearing from people asking us if we would be applying to allow any of these waiver services continue to allow to be provided by legally responsible individuals. And at first we said no. Allowing LRIs to provide 1915K personal care was, as was required under the bill that passed, was already going to be a big enough lift at a time when we have a lot on our plates here at the division. But like I said, we heard from families who were genuinely concerned about losing losing their waiver services altogether unless they were able to provide them through legally responsible individuals. And we got some technical assistance from CMS in understanding what we would need to do. And so we reconsidered our decision on keeping the door open to allow this possibility. So here's where we now stand. The Appendix K flexibility, allowing legally responsible individuals to provide day habilitation and respite, will end on November 11th. We've known that for some time, and that's not going to change. The reason why, those are tricky services to allow legally responsible individuals to perform, and would require a lot more quality assurance and development than we would be able to provide. But we were willing to change course and provide the opportunity for ResHab, in-home and supported living to continue permanently. And I want to emphasize that even just these two services being allowed to be performed by LRIs is cutting edge. All the effort that we've seen other states devote to LRIs providing services has really been focused on personal care, not habilitative waiver services like in-home supports or supported living. My colleagues at SDS, Lynn Kyleman Cruz and Caroline Hogan, and a few other people, just went to a national conference for senior and disability services where this was a hot topic. And Alaska really seems to be uniquely out there in considering allowing LRIs the ability to perform these services. And we have no guarantee, because this is so cutting edge, that CMS is going to approve it. But given what we've heard, given CMS's apparent willingness to work with us on this, we are going to try dipping our toe in the water and explore this further. So next steps. The waiver amendments are out there for public comment right now. Perhaps you participated in a webinar yesterday that Deputy Director Lynn held yesterday, where she talked about other waiver amendments that are in these same documents on specialized group home and specialized family home habilitation. Because these are two very different subjects, we decided that we would have two different webinars. So the waiver amendments are out there. I'll put a link up where you can read them. The final waiver amendments would need to be submitted to the U.S. Centers for Medicare and Medicaid Services by November 11th. So while we're in this public comment period, we're eager to hear from you. We might be making tweaks and changes to the waivers as they're now proposed. But by November 11th, we would need to submit to CMS the final changes we'd like to make. And then following that, we need to begin work on regulations. And that's the regulation in particular that we would need to change, 7 AAC 130-202. Now, in the proposed amendments that you can read, you will see that we have already placed proposed guardrails in them. Oops, just sorry about that. There we go. So yeah, we have placed proposed guardrails in the waiver amendments for residential habilitation, in-home supports, and supported living. There's a long list of them in there. I'm not gonna read them all, but I'm just gonna point out some of them to you so you can get a sense of these. And that, for instance, an LRI will not be approved to provide more than 40 hours of paid services within a 7-day period. The LRI must meet all provider qualifications and requirements to provide the service and comply with provider conditions of participation and residential habilitation conditions of participation. The LRI must be employed by an SDS certified home community-based waiver provider. Here are some more examples of some of the guardrails we've placed in. That the service delivery must be cost effective, like all waiver services. The use of the LRI must be age and developmentally appropriate. The use of the LRI as a paid provider must enable the person to learn and adapt to different people and form new relationships. So again, I'm not listing all of the guardrails that we've placed in the waiver amendments, but the ones I wanted to point out here, you'll note that they're habilitative. That is, they're intended to help people get to a better place for functioning in their homes and communities, unlike personal care, which is assistance, simply assistance with activities of daily living, right? So again, please look at the waiver amendments and the guardrails that we've proposed and provide comments to us. Where can you find those proposed amendments? They are on the SDS webpage. Go to our homepage, and under the field of topics that are entitled of interest, you will see a link to HCBS waivers, and then the waivers are linked and easily accessed there, and the proposed changes are highlighted within those documents. In summary, here's a graphic that attempts to wrap up what I've just talked about and where things stand. And my thanks to Delight Mells here at SDS for putting this nice graphic together. She kind of color coded it here with green light for community first choice personal care services. That's been approved under Senate Bill 57. And though the regulations need to be written, it's authorized and is in place permanently. Yellow light for in-home supports and supported living. These are our waiver services. They're authorized under Appendix K, and approval is pending on them. But because they are in the Appendix K, they do continue. Other HCBS waiver services like respite and rehabilitation are allowed in the Appendix K for now, but that flexibility will be ending on November 11th, 2023. And there's an asterisk here that notes, according to regulation, and this is in place now and it will remain in place, that a guardianship decree by a court may allow for an LRI to be a paid provider for waivers, some certain waiver services. And then finally, state plan PCS. As I started out the presentation today, I mentioned that that's been authorized under the Section 1135 disaster relief, but that will be ending on November 11th. 2023. All right. Now it's time for us to go through questions or receive comments and allow you to unmute if you'd like. I'm going to turn back to Kara and let her sort of summarize whatever Q&A has been coming in. I'm not able to see that at the moment. So I'm going to ask Kara to summarize it and see if there's anything that I can answer from here with the assistance of the team here. So again, look for that orange arrow if you haven't accessed the Q&A or chat yet, and type those questions into the question box. And if you'd like to have your mic unmuted, let us know that, and Kara and her team will unmute the mic.
Absolutely, thank you, Tony. So yeah, for those of you, of course, all of us are on a device of some kind, internet connected device. You should see a taskbar or control bar where you might see a little orange square with an arrow in the middle, and that should open up an area where you can text chat to us. So you can write in your comments. What we'll do is we'll take a look at them and we'll just sort of summarize, since this is a session where we're welcoming your thoughts and your ideas along with your questions. Not everything will be a question. Also, a lot of the times what happens is people will put in sort of the same themes. So we look at them for themes, and if we don't call out your particular comment or question word by word, just know that we do have it on record, and that several folks have the same thing on their mind. So we'll sort of summarize it like that. We will be posting a recording of this session on our Policy Units YouTube channel. And we also will have the slide deck available to you by email for those of us who have attended today. So go ahead and text them in. We'll spend some time with our texted in questions, and then we'll go to audio sharing. You can write to us and say that you would like your audio unmuted, but you can also, it might be a little easier to locate on your taskbar, there should be a circle with a little hand in it, and that is called raising your hand. And that's how this system it lets you raise your hand. So if you raise your hand, then we know that you want to share by audio, and I can go and unmute your audio, and then you can speak and interact with us that way. Okay, so let's spend a few minutes with our questions first. You may also get some written response from our, within your question, from our team here at Senior Disability Services. We are able to give quick answers or basic answers by text as well. So you might see some of that happen. And as always, just know that this is not the only chance that you have to interact with us to provide your comment and your thoughts. You can always email our policy unit at the email address that you see on your screen, hss.dsds.policy@alaska.gov. Okay, so let's check out some of our questions and comments. Folks were thinking about guardrails around an LRI being a paid worker. Some suggestions came in, such as limiting the number of hours per week an LRI could be a paid worker. And then there are some thoughts about verifying hours worked, a standard, suggesting a standard. An LRI needs to use needs to make sure that basic medical or dental care is done, daily hygiene and meal routines are completed, and medications are given, and that the LRI take at least 12 hours of training per year like any other staff. The suggestion also says if hospitalizations or critical incident reports start to increase, there should be a review of that to see what, if any, would be caused by negligence, and a review. There's thoughts about a court visitor being part of the story as well. In cases of guardianship, there is court visitor to the person every few years, so maybe there could be a way to tie in that kind of oversight as well. Some of the other suggestions here, there are some questions about the thoughts that we had posed regarding dehabilitation. Currently, LRIs can provide in-home supports and supported living. Dehabilitation, the question is, how is it more risky to providers allowing LRIs to provide dehabilitation? It's a valuable service. Losing it without ability to have more staff available to just provide it would lead to a lack of socialization for people and possibly create behavioral challenges or aggression and put people at risk. Okay, a few of us had that same thought. Comment says a natural parent with a minor child doesn't have a way to request an order to allow them to provide services through the court. Could there be a separate process for that? A couple other questions here, or actually a comment. Having a second legal representative to sign timesheets and to oversee the services if there's an LIR or LRI doing this would be a good recommendation to make sure that there's an impartial management of those things.
Carol, let me just say, this is great feedback. Really appreciate those people that weighed in with them. I'd like to just mention, I certainly empathize with people who are right now providing dehabilitation to, say, a child because of a lack of caregiver. It gets to be, like I mentioned, though, it gets to be a tricky service. And one of the things I mean by that is that one of the things CMS is going to be looking at closely is how the care for a person with on the waiver and the care that the LRI will be providing is extraordinary care. This is the concept of extraordinary versus ordinary care is something that's mentioned frequently in the guidance that we have from CMS. We're still deciphering that guidance and trying to understand it. But when you talk about dehabilitation, access to the community, you're getting really close to a service that a parent is normally expected to provide to a child, for instance. And while I recognize and appreciate that you know, my nephew, for instance, to get him out in the community requires a great deal more effort than it does for my brother's other children. It brings us into, it just brings us into uncertain territory, especially as far as CMS is concerned. So we, like I said before, we're going to dip our toe into the water with in-home supports and supported living. It's already a bit of a stretch, but it's not to rule out that we wouldn't look at other services in the future. But we're going to start with these two waiver services and see how that goes, see how safely it's being done, see if we have the right guardrails in place. So wanted to both empathize and just explain a little bit about why we're leaving dehabilitation out of the mix for right now.
Thank you, Tony. There were a lot of questions about that, so that helps. Many of us wrote in the same kind of thought thread there, so that really helps. Here's a question or a request for clarification. What is the reasoning behind the decision for a 40-hour work week and 7-day period? Is that a 7 consecutive day period, or is it even that specific yet? Many are working with people who need supports every day for a longer period of time.
Yeah, right now I'm pretty certain, and Jordan or others on the call can correct me if I'm wrong, but it is intended to be in a 7-day consecutive period, and for 40 hours a week. And again, like I mentioned earlier, when you're talking about legally responsible individuals, you're often talking about a person who lives with another, and it gets very difficult to make the distinction between when work is occurring and when work is not occurring. We get that, but 40 hours a week is all that most of us are expected to work in a work week. Getting beyond that gets very complicated. So again, in the interest of dipping our toe in the water and putting some safeguard rails up, that's where we're going to start. That's where we propose starting, I should say.
Another theme around that is, would this also affect somebody who's a court-appointed LRI with permission to court language in the decree that says they could be paid? Would they be subject to the limitation like that?
I have not contemplated that. That's a great question. I see my colleague Lynn Kyleman Cruz has popped up on my screen, so she undoubtedly has something to say. Lynn, did you want to add anything?
I was just going to say, to reiterate the fact that when no matter who you are, if you're a LRI or a regular DSP working, you have to connect with an agency and you have to become an employee of an agency to be able to provide the service. And most employers have 40-hour work weeks, and there's a whole Fair Labor Standards Act that comes into play for more time than that. So it's really important that we don't try to impose that on a provider. A provider, I would just like to point out as well, always has the right to refuse to hire someone. And so I just want to point that out. It's not a given that you can go and become an employee of an agency and serve your person. So I just wanted to point out those couple of facts.
Right. Thank you, Lynn. Yeah, and I hope that's appreciated by those agencies that have expressed concern and a little bit of anxiety about this change. They do retain the right to not participate.
Thank you. Some more themes and great questions, everybody. Keep them coming. There's a few comments around staffing being difficult to fill. Agencies struggle to find people to fill hours. This is sort of the heart of the issue, so I thought it was a good comment to highlight. People may go without services if LRIs are not permitted, and LRI will no longer be able to get gainful employment if they're home caring for their individual due to lack of staff. It
Yeah,
doesn't
Kara,
cost.
that's like you
Yeah.
said, that's pretty much the heart of the matter. We are making these changes because of the workforce challenges. I think if we did not face these, this probably wouldn't be a conversation we're having. But the workforce challenges are extraordinary, and this is one way we might be able to help with that.
Mm-hmm. A few of us are parents and caregivers, saying that I can do more things with my child in a day hab environment than someone who's not comfortable with my loved one. There is a difficulty of providing staffing regarding the person to meet all of the hours that they're approved for. Many comments about the concern of a caregiver shortage, that Alaska is cutting edge, yet we do have a caregiver shortage. This is a shortage experienced by all states. Some thoughts about how it would be typically or atypically unique in Alaska because of our setting and the remoteness or rural nature of some of our living locations and the amount of people who live in the state. Other thoughts here? Okay, thoughts about, there's lots of thoughts about parents staying with people who experience behavioral challenges or circumstances that create the need for complex and coordinated supports. They are oftentimes providing these supports and unable to find staff to do so. So the thought here is that this would help with people being a caregiver to both a child and an adult loved one. Lots of thoughts around those similar themes. Okay. I'm still looking. I apologize for the silence as I look at these. How would someone adhere to the guideline? The use of the LRI as a paid provider must enable the person to learn and adapt to different people and form new relationships from the safety of their inner circle or home. It seems more applicable to day hab, which isn't at the moment planned to be allowed. Comment about day hab. Identifying conflict within the statements. Good comment. Some questions about other kinds of combinations of services. Per PCS regulations, a person cannot have both in-home and PCS. Are we looking to change this with the regulation change?
That's a great question. I don't believe we're entertaining that at the moment. Lynn, did you want to add anything?
No, I don't think we're entertaining that at the moment. It would be great if the commenter wanted to put in why they think that should happen or what exact changes they think need to occur. That's always helpful to us to get more details on specific things. Don't put names, but specific types of cases would be great for us to understand the issue.
Right, Lynn, I can't see the comment, but I mean, this is getting toward the existing thing that we have to be careful about, which is duplication of services, right? Having someone receiving both personal care and in-home supports at the same time is something CMS would see as a duplication of service, I believe.
Yes, we constantly have to contemplate those types of things where there's either duplication or you know, as Tony indicated earlier, there's a natural duty to support. So sometimes we can't supplant school when school is supposed to be occurring. We can't provide a service during that time. There's things that parents normally do in the course of a day that we can't, Medicaid can't duplicate or can't supplant. And that's why CMS is so careful about allowing legally responsible individuals to provide personal care as well. So it becomes quite a challenge for us to present cases that don't have a little bit of border that we have to sort of very carefully contemplate in our rules. So any kind of comments you can give us are really helpful to us, especially specific situations that you might have. But again, no names in here so that we can share with a greater audience.
Correct. Yeah, this is not a HIPAA protected or encrypted session, so we don't want to share names or medical information at all, just generic concepts. Those are welcome. A few of us have asked for clarification on how to comment. If you're in the webinar, look for the taskbar on your device. It should be a little rectangle with a few different icons in it. One of them will likely be an orange square with a white arrow in the middle. That can open up the questions area. It might say chat or questions. And that is where you can text in your question. The other one will be sharing and asking a question by audio, meaning over your connected device. You'll have to have a microphone or be on a smartphone or something that is connected to the internet through audio. And you can do that in just a little bit. We'll give a few more minutes to our texted in questions here, and then we'll try some audio sharing. And at that point, you would just hit that little circle with the hand in it to raise your hand. And then we'll unmute your audio and just take turns with folks who want to share over audio.
Kara,
So, yes.
I did see one question about, could we clarify if a trustee is considered a legally responsible individual, or could be collecting rent at the same time they're delivering a service? These are the types of things that are very difficult, because it depends on how you define trustee and whether we include them in the definition. But also, we're always looking for those conflicts of interest, because that's what our federal partners really want to know. Do you stand to benefit from the person in a way that is not transparent and obvious? And if you're directing a service, does it benefit you more than it benefits the person, basically? So we would have to carefully look at that as well. It's a great question. Those are the types of things that we really like to see, so we know how to define it and how to put some guardrails around it. So appreciate the question.
Mm-hmm. There's a few comments about the 40-hour work week, and that Medicaid doesn't reimburse differently if the person works overtime, and the agency could possibly be the one to decide. My best thought on that is to bring that forth as a suggestion. We're looking for your ideas about how things might work too. So if that is a suggestion that you'd like to have in here, many of us already put that in as a suggestion, so thank you. It's hard to say yes or no to that, is what I'm saying. We're really looking for ideas and your thoughts.
Mm-hmm. And also, just to remind folks, when we're seeking your engagement now, we have not started the formal regulations process for these changes, at which time, as many of you know, we have to be more careful about engaging with people, because we need to ensure a transparent and fair and open process. So this is the time. This is the time to explore things and ask questions, and we can back and forth more than we would be able to once the formal regulation process begins. So, but when that process does begin, be assured that we will have a public comment period again, where we would put draft regulations out for another round of comment, and be able to gather it up then too.
Mm-hmm. And you could always email at hss.dsds.policy@alaska.gov at any time. Okay, so we're always open to getting your email, not just during the session or participating in the session, but at any time. Suggestion says it would be beneficial to have a process outlined for waiver recipients who come into the custody of OCS. And what happens to the role of the LRI at that point if they've been providing services? Also to define what a LRI is not. Does it include a relative at the same physical address who does not have any legal or financial responsibilities for the person? Suggestions.
I think there's another comment in the chat, Kara. It says, can you please address the pink columns on the expiring LRI flexibilities and whether those were considered or will be in the future? And I think those pink columns, we listed them as red, but they're pink. They are whether we would consider future habilitative services. I think it's way too early for us to be able to say that. That would be my best answer because, like Tony mentioned, we're dipping our toes into the waters to do any kind of habilitative services. When I was at the conference recently, I asked a lot of states if they were offering any kind of LRI flexibilities within habilitative services, and their answer was always no, and they would be watching Alaska. So I guess it depends on how well we track it, how we report on it, how well we do with it, and whether or not we could be, again, cutting edge. The other one in that red box is the 1905A state plan services, regular state plan. And that is a limitation CMS imposes and do not allow legally responsible individuals to provide care under a state plan personal care service. I don't expect that to change anytime soon from the CMS perspective because they still flag personal care assistance as one of the highest services that has fraud in it. And so I don't expect them to change that. But, you know, as times change, people change, rules change, that could be something in the future as well.
And workforce shortages continue. Yeah.
Yep.
Lynn, one thing that you and I talked about upon your return from that conference was, you know, every state's waiver programs are different. And if any of you out there are thinking, well, you have a relative or a friend or a colleague in another state who seems to be allowing a service that we are not entertaining here in Alaska, it would be interesting to see, learn more about that, because the rules that apply there are probably not going to apply here. They're going to be different. But nonetheless, we'd be interested in learning what you know. We've researched other states as much as we could, but every state's different. The details are really complex. But so I guess I'm cautioning people against comparing what another state might be doing and wondering why we can't do the same thing. But two, they may have lessons for us that we'd be interested to hear. So if you're following up with us with some comment about another state, we'd be interested to hear it.
Yeah, the interesting part, I think, for us, we talk about this internally, is about language and the way we call certain programs or certain, we define, you know, representative differently maybe than another state would define a legal representative. And so it really does take some careful conversation to know that you're talking apples to apples and not apples to oranges, which is what I think you're trying to say, Tony. And it's complicated for us as well.
Yeah, thank you so much. More comments coming in, and we'll give it, like I said, just a few more, then we'll go to our audio. Some thoughts around the separation of duties of a parent or LRI to a person that would be unpaid, considered core duties for that person, and then what constitutes over that in terms of paid care being given for what's over and above that. So the thought here is to define that. in ways that people can understand. So people understand, you know, what is the expectation, what is a regulatory explanation or an official explanation of what are the duties that are given by an LRI or the parent guardian figure in a person's life that are considered essential and wouldn't be paid, and what would be something that's over and above that that could potentially be paid. So there's that, and there's questions and or not questions, but comments about if an LRI is providing paid care and that care includes some duties such as tube feeding, which may not be allowed for DSP or PCS care, but they're a trained person and know how to do that, would they still be allowed to do that? How would that factor into their paid time? Or would we allow those kinds of cares in this particular situation in language and in our proposed regulation? If an LRI is providing supported living or in-home supports, would they still be considered the unpaid primary caregiver for respite services?
That is a very good observation and something to consider. Kind of depends on the makeup of the home, but that's a very good thing for us to ponder, because respite is intended for the primary unpaid caregiver, and if you are both of those things, you wouldn't. I don't know how we would do that. It's a good question.
Yeah, I mean, as you can all see, that's almost like every circumstance is different. And that's the trick for us, is to write regulations that that are applicable to the most people possible and as fair to the most people as possible. So that's one reason why and we need to run them through the Department of Law to make sure that we're not misspeaking anywhere. So it's a time-consuming process, and we appreciate you bearing with us.
Mm-hmm. And some thoughts about LRIs that are still needing a break. People have been doing a lot of work and they wish to have other staff available or respite staff available so that they could also have a break. You would still need a day off. Some questions about adult recipients having day habilitation. They have an LRI doing the service right now. What will happen? Will they just not have any day hab after November 11th, which hardly seems fair? My best suggestion to that is that the person would need to either establish court language in their guardianship decree for the person to be, for the LRI to be a paid staff, or explore finding ways to find staff. And this was addressed in our FAQs.
And that doesn't always work for if you are a parent of a minor child. You can't get a court decree because again, there's a legal obligation that you already are the guardian, which is why the court doesn't appoint you as a guardian, because you are the guardian, which is one of the things that CMS is very careful about, because you, as the parent, you have an obligation to a minor child. If that were an adult child, it's a different scenario. It's complicated. It makes it very complicated. And, you know, unfortunately, without the rule in place that we can continue to pay a legally responsible individual for day hab, they would have to get either that court decree if that's applicable to that situation, or they would have to find another worker to fill that role, because we can't continue to pay after November 11th.
Okay. What I'd like to do now is go ahead and try opening our audio. for audio, sharing audio questions, if we can do that. Let's invite you to use the hand raising, and it might take a minute for it to catch up. But if you could hit the hand and show me that you're ready to share a question by audio, I can unmute your audio. And if you want to continue entering questions into the question box, that's fine. We can always jump around and go back to those if we want to. It's up to us. So.
Hey, Kara, can you hear me?
Sure can. Yeah.
I'm just, I don't know why, but my sound is really struggling right now. I'm doing my best to track questions, but I might need you to repeat them, just so you know.
Okay. We can hear you fine. Okay, so if anybody wants to share over audio, ask us a question on your device with the microphone or smartphone. Go ahead and hit that hand, raise your hand. We'll give just a second for that to, okay, I see a few popping up. All right. So I'm gonna go ahead and unmute Andreas, and you'll have to unmute yourself, and then you can share.
Hi, can you hear me?
Yes.
Hi, thank you guys for doing this today. I appreciate it. You guys asked for specific situations, and I'd like to bring one up that we experience. First, I help manage a personal care agency here in the Valley. I also have a son who receives services, and I'm the guardian of my adult sister. So I've kind of got several angles going on this. I have one situation where I have a mother who's a licensed nurse who is working full-time. Her husband works full-time. And she has a child who has extreme medical needs and also some other developmental issues. And it's a very high demand job, very stressful to provide that care. And I, as the guy who does our hiring, am always aggressively recruiting to try to hire people and get them through training and hurry up and wait for numbers and background checks. Have a hard time staffing clients that are, for lack of a better term, and not to sound insensitive, but low maintenance or easier clients to work with, much less one that when he starts aspirating, his O2 levels go down and it could be detrimental to his well-being or his health. And the mother, who is obviously very dedicated and very skilled uniquely to provide for her child, is in a position where she won't be able to, further affecting her her ability to provide that good safe home for her child and still provide the care. So she has to choose over which one. Whereas if she was approved to do said services, not only is she licensed and skilled enough, but it wouldn't cost SDS any additional money, or whoever is funding that any additional money, because the services are already approved. It doesn't pay differently if it's a LRI. Just like I mentioned before, that the overtime, we don't get to bill overtime at a different rate. We get paid a flat rate as an agency, and then we pay the provider overtime. So that's my main thing there, is just trying to find staff. And we have a lot of people with our agency who are going to be not able to bill for their care, which makes it more likely that they could lose their care for not actually using said care, because there's no billable provider to do it.
And Andreas, are you talking about personal care primarily?
We also do waivers as well. This one would be on waivers. The specific individual I mentioned is 3 years old. He's a minor. He's 3. He's not older to where he could get that care because he's an adult who has his parent as a guardian. But we provide both services, and I can see heavy effects on both sides, PCA and waiver, for our agency.
Well, thank you.
So that's all I have. Thank you guys for your time.
No, I appreciate that input.
Thank you. Let me find the next person who wants to share by audio. I'm going to go ahead and unmute you, Heidi. You'll have to unmute yourself. Go ahead, Heidi.
Can you hear me?
Yes.
My comment can be short. I just because I want to echo what the previous speaker just stated. I am a parent. I am an LRI providing care to my minor child, 4-year-old child, who is medically complex, and I also happen to be a nurse, and I am working full-time, almost full-time for my child right now, and she is medically fragile and losing my role as a paid care provider for her. It's the same situation. I am losing my financial income to help support my family, and also the safe care that my daughter, my medically fragile daughter, needs, that I am absolutely qualified to provide. So I just want to echo what the previous speaker said, to really highlight that that is happening for these medically fragile kids that are getting the care that they need from their LRIs. So just repeating that. Thank you. And thank you
Can I
for
ask you
providing.
a question, Heidi?
Yeah.
What specific service are you talking about that you provide now as the caregiver?
I am providing respite care and rehabilitation. So I would be losing all of the services.
Thank you. Appreciate that.
Yep. Thanks.
And Heidi, I have questions too, but I want to be careful about, getting too much into the details about the specifics of your child's case in this
Sure.
public forum. I'd love to hear the details around why what we've proposed is not helpful to you. And if you can follow up, take a minute to email us. Really would appreciate it.
Okay. Thank you.
Thank you, Heidi. Okay. Let me unmute my next person who has raised their hand. And I'm going to unmute you, Sarah F. Okay. And go ahead and unmute yourself.
I am here. Can you hear me?
Yes.
Okay. Well, thank you for letting me speak. I think that it's a really great idea. I do have a few people I support who live in rural areas and who have kind of intense behaviors. And while there may be staff in those areas, those staff aren't trained at a level where they're comfortable working with those folks. So sometimes the parents are the experts, and most of the time experts. So allowing them to work with their adult loved ones is essential, I think, because if you can't go to work because you have to provide that care, then how do you make ends meet? How do you pay the bills? How do you do those things? I do think that it would be very helpful for us if there's a requirement that there be a legal payee who is not the legally responsible individual, so that there's at least some accountability for what's happening in the person's life. We can make sure that there's not financial abuse or anything untoward happening. And I think it would be really useful for care coordinators, for agencies, if there was like a handout of guidelines or guideposts, like these are the general expectations, like, people need to make sure that they get to their doctor's appointments, that hygiene routines are done. We need to see that there's not an increase of hospitalizations, that there's not an increase in critical incident reports. We don't want to see that somebody is deteriorating. We don't want people to feel judged, but we also need to have some basic guidelines to hand them and say, okay, if you're going to do this, these are the things we want to see, that, the home is somewhat clean, that, there's basics that are being done. And if we see that these things aren't happening, then maybe this isn't the most supportive method for your family or for the person. But it would be helpful, because otherwise we're in a position of trying to advocate for an individual where ordinarily a care coordinator could give feedback to a caregiver and say, well, maybe try it like this. But you're also talking to the person who signs on whether or not you are a care coordinator. So you're in a really precarious situation where you're advocating for the best interest of the individual, but you don't want to insult or anger the employee who's also your boss. I don't know if any of that makes sense.
It
But
makes
having
total sense.
something, yeah. So having some kind of basic guideline that we can review together and say, how are you doing in these areas? You know, is there something that we can do to help you achieve these things or whatever? It would help us to make sure that things are better. I don't know. Anyways, thanks for the time.
I really appreciate your recognizing the need for what we call program integrity around here. Lynn over there has spent much of her professional life trying to work to ensure that the services that we provide are quality. And I really appreciate you recognizing that's a critical need as you allow this window to open, that you need to be careful about protecting recipient choice, protecting the integrity of the program, protecting against wasteful use or fraudulent use of this allowance. So I wanted to say that I have heard from many people that this doesn't go far enough for them. I've heard from people say that they wanted to see the LRI flexibility extended to services that weren't allowed even under the pandemic to be provided by LRIs. I would be interested in hearing if there are people that are receiving in-home supports or supported living for whom this would be of benefit, so that we can just be aware of how this will benefit them. That would be great feedback to get too.
Yeah, and I wanted to add a comment to that as well, Tony, because I think it is really hard because I hear the angst and the anguish from parents that are providing care, and I'm sure very good care to their children, because we also have the flip side of that. And I'll just talk a little bit about it from the program integrity standpoint. You know, for adults, many of our perpetrators for adult protective services end up being family members. And so it's really difficult weighing that balance. And it's not to say that people in our services that are providing care are those people. That's not what I'm trying to say. But we also have to have sort of these guardrails that we're talking about. Are those ways to ensure that the service is really being delivered and it's being delivered in a way that offers choice and that the person is benefiting from it? And sometimes, you know, people have ideas, well, we should just have QA look into that. You know, we have a very small team in QA. So we need guardrails that apply, that we can enforce pretty quickly. And we also need a way to say to a parent, if we find that they are not meeting the mark and they're not delivering a quality of care service, you can no longer be the paid provider. That's always a difficult thing for agencies to do and for SDS to do. So we're entering a new territory here where we're going to tell a parent that your house isn't clean enough for your child. That gets really tricky and not necessarily somewhere we want to go down. But those are the kinds of guardrails that we have to sort of consider here. And I know for parents that are applying the service now and doing the service, we really want to hear from you about how you think that would work across, you know, all providers, not just you being a good provider, but all providers. That would be helpful to us.
Thank you, Lynn. Okay, our next hand raised here is Sarah N. I'm going to go ahead and unmute your audio, and you have to unmute yourself. Go ahead, Sarah.
Hey, can you hear me?
Go ahead. Yes.
Okay, good. So I think Andy and Heidi brought in a great segue into what my biggest concern is, and Tony, I know you know who this is. Nice to see your face. Um, I think we really need to address the kids under 3 years old. There has to be some type of lenience, flexibility. We need to look into how complex and fragile kids like my own and like Heidi's are, that this isn't, something that happens after the age of 3 or after the age of 6. This is complex. This is nursing level. The complexities is seizure precautions, aspiration, anything that could be a part of a child's medical complexities that does not allow a parent to leave the home for work. So, we're going to single income families. And I also, Heidi, I'm a registered nurse as well, so I feel your pain. It's almost as if the moment the incident happens, at whatever age that may be for the young child under 3, at least for me as a nurse, I never left my job, but I'm not getting income from it. It's a blessing to be able to fight for my child this way and to be here and really push him through his goals and participation through his goals. But the problem is, how am I going to be able to consider doing that if I can't keep the roof over his head because I am not apparently allowed to be qualified for these services because he is under the age of 3?
Thank you,
Hi,
Sarah.
Sarah, I appreciate being able to hear from you again. Our conversations were one of the factors in prompting us to take a hard look at this. So I've appreciated you weighing in. There's been an interest I've heard expressed about personal care services being more readily available to very young children. And the challenge there is, as I understand it, is that parents need to, obviously, all parents need to provide some degree of personal care for children for very young children, as they learn how to feed themselves, how to use the bathroom, all of those things. I recognize that the kind of needs that your child has go beyond the care needs of most children. But anyway, I just wanted you to know that we've kind of extended this out there, and it's in part thanks to parents like you that have made their voices heard.
Thank you.
The other thing, this is Lynn, the other thing I think is important to say is that sometimes a senior disability service doesn't make all the rules. So we're following some of the rules in our federal programming. And so if you feel like the federal regulations are too tight, or that personal care, legally responsible individuals should be able to provide personal care, that under our state plan services, that is something that I would encourage people to reach out to their federal partners during rulemaking sessions on those types of issues, because I think they're starting to hear that from advocates and parents, and I think it's important to dialogue us into the future. But at this point in time, it's still, we follow what we're allowed to follow. And like we said, we're really trying to be cutting edge here with in-home supports, but we have no guarantee that CMS is actually going to approve this. We're pushing for it, and we are, having the conversations with them, but it is something that we've yet to see how this is going to pan out. So it's hard to think about all services becoming eligible for LRIs.
Yeah, and if the thought of trying to figure out who at CMS to talk to about that is daunting to anybody, you can reach out to members of the congressional delegation who authorize and fund those agencies like CMS. I think Senator Murkowski, Senator Sullivan, Representative Peltola would be interested in hearing about how the federal rules prohibit people from being able to deliver the care that they'd like in the way they'd like.
Thank you, Tony and Lynn. We
And,
still have,
just
go ahead.
Kara, if I may, it was advocacy to Senator Giesel here in the state that really made the change occur around 1915K community first choice programs. She talked to the division about how she was hearing this was important to people, and she wanted to make it a priority that the gap not occur when the flexibilities ended on May 11th. So it was thanks to pressure she'd received from parents, from personal care providers that initiated that change.
Thank you.
Sorry, Gary, I didn't mean to cut you off.
Yeah, no worries. I'm just continuing to go to our raised hands. Next up is Tabitha. You'll have to unmute and then speak.
Hi,
Go ahead, Tabitha.
everyone. Can you hear me?
Yes.
Okay, perfect. Thank you guys for taking the time today. My question is just about the process. After public comment ends, and you guys review public comments and possibly make some considerations for change in what's proposed, if there are changes that are identified that you guys make, do we have to allow for another public comment period? And if so, how do we plan to submit by November 11th?
I don't think so. I think we don't have to go back around. I think what we need to do to CMS, and Lynn, you've been through this process, right? I think we need to go back and explain to CMS about why changes were made in response to that public comment. They'll want to know what we did with the public comment.
That's correct. So we take all the public comment and then we go back and look at the things that we proposed. So let's say, we get 5 more guardrails, or people think 1 guardrail is too complex and we want to remove that. Since then we will do our final draft and we submit that to Centers for Medicare and Medicaid. We have not yet submitted anything to CMS. This is in our attempt at a draft. We accept your feedback, then we go decide what can we do across the board and what changes can we make. We consider all the feedback, we put it in for proposed, and then it goes out to CMS. And then we enter into what we call an RAI period, which is a request for additional information, where CMS will look at what we've proposed. They'll come back and ask us questions about it. And we, the state of Alaska, enters into this back and forth dialogue with CMS. And then either they approve the service or they sort of force us to make changes to it. And then then they approve the service. Once that's approved, we can go down the regulatory framework, and we will have a time frame where we'll write our regulations and we'll open it up for comment again for folks to give comments on how we regulated it. Did that answer your question, Tabitha?
Thank you.
Thank you, Lynn,
Lynn,
and Tabitha.
I know you went
Go ahead.
into some detail in your webinar about just what touched this off. We received word that if we submitted changes to waivers before November 11th, then the Appendix K flexibilities that were related to those changes could be maintained while the process, but the dialogue between CMS and SDS got underway. So that's why we got the proposed amendments together really quickly. We had a full 60. We had to get them out for public comment a full 60 days before November 11th, because we both had to ensure a 30-day public comment period and a 60-day tribal consultation period, which is happening at the same time as the public comment. So we got technical assistance from CMS on those amendments. We put them in there, and they're out for you now to comment for another couple of weeks.
And the biggest part about that, and the reason that we don't have time to come back out and say what we formally put in, is because we will be right up until that deadline in November by the time this period ends. And we have to submit by November 11th, or we lose the opportunity to extend our Appendix Ks at all.
And then there'd be another
So,
gap.
right, we would have a gap. And so we're under very tight timelines with CMS to be able to do this.
Thank you. Okay, our next hand raised here is Jamie. Go ahead, Jamie, you'll have to unmute and then you can speak. All right. Looks like Jamie. Jamie, are you ready? If not, that's okay. We can leave the hand up and come back. Okay, no worries. Next one here is Amber M. Go ahead, Amber. You'll have to unmute and then you can share your question.
Hello, can you hear me?
Yes.
Hi, I wanted to first very generally explain my personal situation and then ask my question. I have a minor child, let's say they're between the ages of 7 and 10, very complex, rare condition with less than 1,000 cases worldwide throughout history. I have become his quote unquote expert, and I am an LRI. And I was wondering because they're currently under the CCMC waiver, and that, I mean, by definition says that children who experience medical fragility, often dependent on frequent life-saving treatments, interventions, or are dependent on medical technology, or the child would otherwise require a level of care provided in an acute care hospital or nursing facility. And I guess my question is that doesn't that meet the definition of extraordinary care, because they would meet the requirement of otherwise being in a facility? And if they were able to subsequently be able to petition for a court order, how would that be different from what's already in place?
Sure,
I
I
can,
can take. Oh, go ahead.
no, you go ahead.
No, I was just going to take a start at it and first of all say, Amber, I feel for you. That's a lot, and the concept around extraordinary care, it relates to who's providing it. It's extraordinary versus ordinary care is who's providing it, and again, this is kind of stepping out there in a way that CMS has not allowed in the past. And so while I appreciate what you're saying, it's new territory for CMS, and they are urging us to proceed with caution in how we allow these services to be provided. So I'm sorry, Lynn, go ahead.
I was just going to say that the definition that you read off is really that your child and everyone on the CCMC waiver meets that nursing facility level of care or the intellectual and developmental disability level of care, depending on what waiver you are on. But everyone then would qualify for extraordinary care under that measure. So CMS asks us to go beyond that and say, well, what about this person makes it extraordinary for a parent or legally responsible person to have to perform extraordinary activities for the person. And that is kind of the crux of what we have to explain. You know, CMS also makes it seem very simple sometimes, you know, just check a box, fill out a waiver, you can do it. But at the back end of it is when they ask us all the questions. Well, how are you going to insure? How is this different from a regular parental obligations? So those are the kinds of things we're willing to do for one service and try and work through that with CMS and see what we can get through. And then, you know, we can reevaluate. But I can appreciate your situation, as most, you know, parents that are taking care of very complex children. It's a very difficult situation to be in. So appreciate your comment.
Yeah. One thing I've learned since coming here to SDS, CMS is a whole bunch of silos. And when we submit our waiver amendments to them, it's going to make stops at each of these silos where, you know, the quality assurance people, they're going to look at it with their eyes, and the program people are going to look at it with their eyes, and everybody kind of takes a different angle on it and will come back at us with highly detailed questions. So it'll be really interesting to see, because like Lynn said, it's easy for them to say they're throwing this open to us, but a lot of people whose job it is to ensure the integrity of the programs at the state level will be looking at it from a different angle, and they're going to work us over on it.
And that's what we call operationalizing all of these programs, which is really a difficult thing for us. But we're willing to step to that task. It's just a lot of parts and pieces that we have to go through. But I think we're out of time, Kara.
Yeah, thank you, Lynn and Tony, for this wonderful presentation, and thank you to our audience for being part of it. I know we still had a couple of hands up, but we do need to go ahead and close our session because of time. I encourage you to please write your comments to our email, hss.dsds.policy@alaska.gov. We're very much eager to get your feedback and your comments, and we appreciate you being in this session and spending this time with us here this afternoon. Please feel free to, of course, interact with us at the email address. Check your alerts and other notifications for next up webinars. We have another one next week about adult host home, and just stay connected with us for further communications and the recording. Tony, do you want to say anything else before we sign off here?
Thank you, Kara. No, just really, this has been great input. We are committed at SDS to trying to engage with folks as much as possible early on in the process before we launch into the more formal processes. We're going to continue to do that. So thank you all for being part of this.
Okay, so goodbye for now. We hope to see you in a subsequent webinar. Have a wonderful afternoon, everybody.